Type 1 diabetes is an incredibly challenging diagnosis where kids and their parents and families have to, act like a functioning pancreas 24/7 without any break. And doing that requires giving insulin, multiple times a day, often six, seven, eight times a day with every meal, snack, and corrections. So, contemporary care is usually the combination of a long-acting insulin given once a day and then a short-acting injected insulin with those meals and snacks, or alternatively, the use of an insulin pump that patients still have to instruct to give the insulin, around those times. So it's not entirely automated at this point. Um, and one of the biggest challenges, regardless of how you give that insulin for meals and corrections, is that even though we call it rapid injected insulin, it's really not fast enough. It takes a good 15 minutes before that injected insulin is even detectable in the bloodstream. And sometimes it doesn't have its peak effect for closer to 45 minutes to an hour. And then it can linger for another hour plus. And so it's not, really physiologic. And so the field has long been in search of more rapid acting insulins, truly rapid insulins that can more physiologically cover, meal excursions, corrections, reduce risk for post-meal hypoglycemia. And in terms of injectable insulins, we've made some progress there by way of manipulating the insulin structure so it gets into the bloodstream faster. Um, but again, it's just not fast enough. So there's long been a desire for inhaled insulin. And there have been a few different products that have come to market that, interestingly enough, have mostly been commercial failures, even though they worked quite nicely. And more recently, the inhaled insulin product Afrezza, or Technosphere insulin is the generic name, has been developed and FDA approved for use in adults with diabetes. And essentially, this is a biomaterial technosphere that gets bound to regular human insulin. So it's your non-manipulated insulin. And then when it's inhaled into the lung, these particles dissociate and the insulin is absorbed very rapidly through the lung blood vasculature, allowing the insulin to reach peak levels within 15 or 20 minutes. So much closer to the way a human pancreas that's working should work. And so because of that, it really can provide more optimal meal coverage, safer control of hyperglycemic corrections. It's much better for athletes in terms of not having hypoglycemia associated with insulin dosing. And so it's been successful in adults, although it remains fairly underutilized, I would say, just because the paradigm hasn't shifted so that people think of using inhaled insulin as a first option. Everybody still kind of assumes we got to use injected. Current pediatric use is off-label. Myself and many others are prescribing it that way. Lots of pediatric medicine is off-label, unfortunately. But the intent is to use the recently public INHALE-1 study data to file for approval in pediatric use. Sure. So yeah, INHALE-1 was the large randomized control trial designed to test non-inferiority of inhaled insulin versus rapid-acting analog injected insulin for meal and correction coverage in children with diabetes. We actually allowed children with both type 1 and type 2 diabetes to enroll as long as they were using multiple daily injections of insulin. At the end of the day, there were literally only a handful of children with type 2 in the study, so it is primarily a type 1 diabetes population. But kids from 4 up to the shy of their 18th birthday were able to enroll in the study. And it was a large multi-center study with 30 sites across the U.S. enrolling north of 230 patients at the end of the day, so a fairly robust sample size. And essentially, patients were randomized to either continuing their basal long-acting injected insulin and their rapid-acting injected insulin, or continuing their long-acting injected basal insulin and using Afrezza, the inhaled insulin, for all their meals and corrections, with the primary outcome measure being, change in their hemoglobin A1C after 26 weeks of being on the therapy. And then patients were then crossed over, allowed to have ongoing use of Afrezza if they were in the injectable group, or continued use of Afrezza if they were already assigned to that in the first group, to the end of a year. And we don't yet have the 1 year data. That will be hopefully presented at this SPAD later this year. And the primary outcome essentially showed that there was non-inferiority of the inhaled insulin in comparison to the rapid-acting injected insulin. I say basically because there was one subject who was unfortunately very non-adherent to their insulin regimen, who was randomized to the inhaled insulin group, who, if included in the analysis, made the sample not meet the p-value for non-inferiority. But in what's called a sensitivity analysis, where you exclude this one highly non-adherent patient, you do see that the inhaled insulin group and the injected insulin group behaved almost identically with regards to hemoglobin A1C as the primary outcome. And I think the key to that is that, it's a different paradigm to use inhaled insulin. The folks who are successful with it really give it, as they're eating, and then give a second dose an hour, 90 minutes after the meal to sort of top off the insulin dose. But because it's so easy to use and doesn't require an injection, it really is a nice option for some patients. I don't think it's going to be an insulin for everyone, but I do think it's an important tool that we need to add to our toolbox to help families and patients navigate this complicated disease in whatever way best fits their lifestyle. And so, hopefully getting it approved for pediatrics will give people more level of comfort in using it, and we'll see its use grow. I think the other things that were important that we found from the study that differentiated it from injected insulin was we did see less weight gain in the group randomized to inhaled insulin versus injected insulin. And weight gain is a big problem in patients who require exogenous insulin, because it tends to be a weight positive treatment. And so for folks who are really trying to achieve glycemic targets and fighting against their own body in terms of weight gain, the advantage of an insulin that is slightly less weight positive is significant for many folks. And then, related to just patient satisfaction, the parent and patient, the children in the study satisfaction scores were higher when they were randomized to the inhaled insulin versus injected insulin. So I think, again, these patient-reported outcomes are of growing importance as we practice the art of medicine and try to give patients, the tools to manage their disease in the way that best fits their lifestyle. And if patients are telling you, this therapy is better for them than another therapy, I think that's important, and we should listen to that. And so I think those two additional factors, hopefully are enough to satisfy the FDA and get that label for pediatric use. Not because I think inhaled insulin is going to, replace injected insulin, but because I think it's an important tool that a number of families and physicians will feel more comfortable using once it has that FDA label.